Hello and welcome to our last video in covering chapter 35, discussing alterations of the female reproductive system. In this video, we are going to discuss disorders of the female breast. Now, this next section is going to involve galactorrhea and benign breast disease, as well as breast cancer. So let's start off with galactorrhea. And this is going to be when we have inappropriate lactation taking place, where we have persistent and sometimes excessive secretion of milky fluid from the breasts of a woman who isn't pregnant or nursing. And this can also occur in men, and it may involve just one or both breasts. And these cases are usually due to a pathophysiologic process that's taking place somewhere else in the body and not necessarily in the breast. So one of those cases could be a non-puerperal hyperprolactemia, where we are getting excessive amounts of prolactin in the blood that is not related to pregnancy or childbirth. And this could be due to a couple different things. It could be caused by overstimulating those prolactin secreting units within the pituitary gland, or it can interfere with the production of the prolactin inhibiting factor that is produced by the hypothalamus. Typically it's dopamine that is going to help inhibit prolactin secretion, or we can have an interference with the pituitary receptors for that prolactin inhibiting factor. And we can also have exogenous agents such as certain drugs that could cause this non-puerperal hyperprolactinemia. These can also be high-dose oral contraceptives, or the person could have hypothyroidism, which is going to cause increased secretion of our hypothalamic TSH, which also stimulates prolactin release from the pituitary gland. And pituitary tumors also could be the cause. So then we can have a prolactinoma that causes the hyperprolactinemia by secreting prolactin, which is going to decrease the production of our prolactin inhibiting factor as well. To diagnose this, we can do a variety of tests that may look at the serum prolactin levels, our TSH, so that we can rule out hypothyroidism, and sometimes we may need to measure LH and FSH if the person is also experiencing amenorrhea or other menstrual abnormalities. So the treatment for this is going to be to figure out what the cause of it is and treat that disorder. Now let's talk about benign breast disease, and this is going to be a spectrum, or what I call an umbrella of non-cancerous changes within the breast, and it could include things like lumps, cysts, having some sensitive nipples, and having itching taking place due to changes within the breast tissue. And the most common symptoms will include pain, palpable mass, or nipple discharge. And typically these are not going to be associated with an increased risk of breast cancer, and we can classify them into non-proliferative breast lesions, proliferative breast disease without atypia, and atypical or atypia hyperplasia. So let's dive into some details with those classifications next. So we'll start off with our non-proliferative breast lesions, and these are usually not associated with an increase in breast cancer, increased risk of breast cancer. And although there are many different types, we are going to focus on these three different types. Sorry, I keep losing my mouse sometimes when I record these videos. So we'll start off with the simple breast cysts, and these are just fluid fills, and they are the most common here. It's usually going to occur in the 30s, 40s, and early 50s, and if it is found superficially, it feels very squishy, but if we find it deeper, it can feel like a hard lump. And often they can rupture and release their secretory materials into the adjacent tissues, and that can result in chronic inflammation, leading to scarring fibrosis, which can create a palpable firmness to the cyst. Next, we have papillary apocrine changes taking place, and this is going to be an increase in the ductal epithelial cells that has apocrine changes, or an eosinophilic cytoplasm. And lastly, we have mild hyperplasia of the usual type, where we have an increase of those epithelial cells within a duct that is going to be more than 2, but not more than 4 cells in depth. And the clinical manifestation for this type of breast lesion is going to be a unilateral nipple discharge. Now let's talk about proliferative breast lesions without atypia. And by the way, when we use that word atypia, we're talking about deviation from the normal. So this type is going to be characterized by proliferation of the ductal epithelium or the stroma, or sometimes both, without having the cellular signs of abnormality, which again, we use the term atypia for. And we have quite a bit of lesion types here. So the first one is going to be our usual ductal hyperplasia, which you could see pictured over here as an example in a duct, and here's an example in a lobule. And you can see here how those epithelial cells are starting to fill and distend the ducts and the lobules. Within intraductal papillomas, we can either find them solitary or we can have multiple lesions. So in solitary, the papillary cells will start to grow in from the wall of the cyst into the lumen of the duct. So it can harbor areas where we have atypia or ductal carcinoma. So we may have to surgically excise them if we have atypical cells. Next up, we have diffuse papillomatosis, and this is when we have multiple papillomas that present masses, nodules, and nipple discharge. Next, we have sclerosing adenosis, and we see a picture of this over here, and this is when we have that lobular lesion with fibrotic tissue and scattered granular cells. Here we see pictured an example of radial scars, and this is going to be when we have that irregular radial proliferation taking place of a duct-like small tubule that is encased in dense central fibrosis. And lastly is a simple fibroadenoma that is a solid tumor of glandular and fibrous lesions. Lastly, as far as benign breast disease, let's talk about proliferative breast lesions with atypia. So we call this atypical hyperplasia, and this is when we will have an increase in the number of cells or a proliferation, and the cells have some variation within their structure. So pictured over here in A, we see an example of atypical ductal hyperplasia within the breast ducts. So we'll have proliferation of what we call monotonous cells in architecturally complex patterns. And below that, we can see an atypical lobar hyperplasia. And here we are going to see the acini are expanded and filled with the monotonous polygonal cells, and we start to lose that acinar lumen. And lastly, we see what's called a multifocal atypical hyperplasia, where we see that hyperplasia present in more than one terminal duct of the lobar unit, as well as we see some separation by interlobular mammary stroma, which is where the arrows are pointing to, the black arrows there. And here, this is what our microanatomy of the breast typically looks like, so that we can see the terminal duct and it attaching to a lobule with the different acini. So in this type of benign breast disease, we do see that it's associated with an increased risk of breast cancer. And the younger a woman is when she's diagnosed with atypical hyperplasia, the higher risk that breast cancer will develop. So to treat it, we focus on relieving symptoms, but we also want to do some other lifestyle changes, such as reducing the amount of caffeinated drinks or chocolate that is consumed. We do see that these substances can overstimulate the body, so avoiding them can reduce pain and the nodules within the breast. And over time, cysts can disappear. And you also may want to avoid oral contraceptives and hormone replacement therapy. Now let's shift into breast cancer, and this will pretty much be the last major topic we'll talk about. This is going to be the second most common cancer in American women, and it is a multifactorial disease. So it's going to involve a lot of interacting factors. We know that there is going to be risk factors that can be classified broadly as reproductive, hormonal, environmental, and familial. So we'll talk about that in a bit more detail detail. And also there's some risk depending on the timing, duration, and pattern of certain exposures. And you could see some of the risk factors listed here over on the right-hand side and the relative risk factors here. So the higher you get, the greater risk of developing breast cancer. There are some early screening programs that have been encouraged to women to perform, like self-breast exams, or when they go in to see their gynecologist to have a breast exam in the office. But this can also lead to false positives, and there have been no association with these exams and a reduction in mortality. So most groups will no longer recommend it. And there is also breast screening with mammographies that continue to be recommended. We're going to touch on those in a couple slides. So let's start with the risk factors of breast cancer, starting with those reproductive factors. We do see that there is a reduced risk if you are pregnant at a young age. And we also know that there is development of the breast. It changes a lot throughout our lifespan. For instance, we'll have branching morphogenesis that takes place within the breast, in which the branches are starting to develop as a fetus. Then it's going to pause after birth, and it starts again at puberty because we have estrogen secretion taking place. And then we start to modify it throughout the ovarian cycles and produce a mature ductal tree. And when we get pregnant, those branches are going to change once again. And so that brings us to pregnancy-associated breast cancer. And this is defined as breast cancer that's diagnosed up to 5 years after a completed pregnancy. We think this is due to something called involution, when there's shrinking of the breast structures, so it could return to the breast size before pregnancy, and it may develop due to remodeling pathways that are pro-inflammatory and may promote tumor progression. So let's talk about that involution phase further. As we said, there's a lot of physiological changes that are taking place in the breast throughout life. We go through puberty, pregnancy, lactation, and then there's post-lactation involution, and we've got changes with aging. So typically the breast has about 15 to 20 lobes with its terminal lobules with their acini that can produce milk. And it's these terminal duct lobular units, or TDLUs, that are responsible for lactation. And they also serve as a prominent source of breast cancers. And what's interesting is when we have lobular involution, that's going to be associated with reduced risk of breast cancer. These typically are going to be associated with aging. And then we have post-lactational involution, in which the breast tissue is going to regress and remodel itself to its pre-pregnant state. And this happens when the fibroblasts are going to start secreting proteases, that those basically cut apart proteins. So it starts degrading the extracellular matrix proteins, and then it promotes the growth of tumors. And we could see that change taking place here in nulliparous women, a woman that has gone through lactation, and then we have that regression taking place. And just a reminder that this term nulliparous means that we have someone who has not given birth to a living child. Now let's talk about some of the hormonal factors. We have 6 factors that affect the risk of breast cancer. There's a protective effect if we have an early first pregnancy, meaning the pregnancy takes place within someone's 20s. Then we have a protective effect if we have removal of the ovaries and the pituitary gland. And there's an increased risk when we have a early menarche, a late menopausal state, and our nulliparity. We also see that there's a relationship between types of fat, free estrogen levels, and oxidative changes in estrogen metabolism. And there is a hormone-dependent development and differentiation of mammary gland structures. And you could see that in the image down over here, where estrogen and progesterone are really helping with that ductal elongation and the side branching. And eventually, when we have pregnancy take place, we can have that alveologenesis and lactogenic differentiation when prolactin is present. And lastly, we have the efficacy of anti-hormone therapies for treatment and prevention of breast cancer. So we are still going through and looking at this complex model of hormone, paracrine, and adhesion molecule signaling pathways that are affecting these epithelial and stromal cells in breast development and carcinogenesis. And we see that a lot of the breast cancers are initially hormone dependent. So we could talk about them as being estrogen positive, which is ER positive, and or progesterone positive, which is PR positive. So we have endogenous estrogen as a factor, and we saw that with increasing blood levels of estradiol, we have an increased risk of breast cancer. This is because estradiol can be pro-inflammatory and promote macrophages from the immune system to invade the breast tissue. Then we have endogenous progesterone, and this is going to be when we have repeated exposure during the luteal phase of the menstrual cycle, and this causes cell proliferation within the breast that increases progesterone levels, which can increase breast cancer risk. Then we have endogenous prolactin, which is going to be one of our key regulators for lactation because it helps produce the milk, and that increases our risk level. Our endogenous testosterone, we see with circulating testosterone in postmenopausal women a link to our risk in breast cancer. And lastly, local in situ estrogens that have a paracrine effect, in which we have the formation of estrogens in the breast tumor that assist in the growth and survival of these estrogen-dependent breast cancers in postmenopausal women. We also see that menopausal hormone replacement therapy can change the risk of breast cancer. So the menopausal therapies can possibly be carcinogenic. There's the estrogen progestogen menopausal therapy and estrogen progestogen contraceptives. And over a long period of time, the estrogen with combination of the progestogen can be beneficial in things like making sure that our bones keep their density, minimizing the fractures that we would have. But there's also some harmful effects in having an increase in breast cancer, gallbladder disease, and also some thromboembolic events and possibly stroke. There's still more research being done, so that myth of going through something like estrogen replacement therapy when you're going through menopause, a lot of people fear that, oh, I'm going to get breast cancer if I do this type of therapy. But if it's something that is monitored and estrogen is being given alone, the risk of breast cancer is not increased, but there is going to be a risk of endometrial cancer that is increased. Now let's talk about insulin and insulin-like growth factors. They're going to regulate cellular functions involving cell proliferation, migratory differentiation, and apoptosis. We know that insulin-like growth factor is a protein hormone that has a structure similar to insulin, hence its name. And by using insulin therapy, and sulfonylurea found to be mildly associated with increased breast cancer risk. And we've looked at metformin, and this appears to have a protective role, but we do need more investigation. Now let's talk about oral contraceptives, in which we are using combined estrogen, progestogen oral contraceptives, and we see an increased risk for breast, cervix, and liver cancers. The efficacy of these oral contraceptives in protecting against ovarian cancer and endometrial cancer, though, is well established and researched. Then we have our mammographic breast density. We mentioned getting a mammogram in one of the first slides that we discussed. And a mammography is going to be when we do an X-ray exam that's going to view each of the breasts. And we look at the density there and we will see that if the tissue is dense, it'll appear white on the mammogram. So if you're looking at some of the black and white images on here, we see that there is variation amongst the breast composition. Here in this image, we can see that we have a very fibroglandular or dense breast tissue. That's why we see so much white throughout in here. Whereas here in B, we see a breast that is more fatty, and therefore we see less of that white appearance. And down here at these images, we can see in A here, we have a breast that is almost entirely fat. B here, we can see that we have some scattered fibroglandular densities. Then in C, we see heterogeneous density. In this image, we see that the breast tissue is extremely dense. It's almost gray and white all over. And lastly, we see a breast that has invasive cancer. And this arrow here is pointing to that structure. We do see that there's a significant increase in risk that is associated with a higher percentage of mammographic density when we see breast cancer. Now, these screenings are very important. About 50% of women in the US who are screened annually for a decade will experience at least one false positive examination. So they can cause anxiety, but by doing these exams, we can catch the cancer early on and be more receptive to treatment. Now let's talk about environmental factors and lifestyle. Environmental causes of the breast cancer can possibly affect the breast the most during the critical phases of development. So think of the mitotic activity that takes place, the cell division that takes place during puberty or those reproductive years, in which we're going to have those activities be ongoing more than they are later in life. Ionizing radiation, which we know is a mutagen and a carcinogen for breast cancer. We can have accidental or medically induced radiation, or a woman maybe was treated with chest radiation for a pediatric or young adult cancer that can then increase our risk for breast cancer. Diet is really interesting to look at. There have been so many studies looking at the different aspects of diet and breast cancer risk, although we haven't found a really strong association between the two, except for alcohol intake, being overweight, and looking at the weight gain after menopause. We do see that dietary fat can stimulate endogenous steroid hormone production, which also is going to affect weight gain and the age of menarche, and fat can also interfere with immune or inflammatory functioning, and fat can induce gene expression. Some other aspects would be dietary fiber. That can modify estrogen concentration and stimulate intestinal microflora. So that's a good thing. And another topic that is always up for debate are soy products. We know that soybeans are the main source of isoflavones, which can bind to estrogen receptors, but are far less potent than estradiol. So soy can act like an anti-estrogen by blocking the action of our endogenous estrogens, and that reduces our breast cancer risk. So we see that soy foods generally are going to be breast protective. Something else that is up for debate is utilizing iodine. Iodine deficiency is hypothesized to contribute to the development of breast pathology and cancer. So we see that iodine plays a significant role within breast health. Next, we have obesity. This is going to increase cancer risk from cellular pathways that involve hormonal regulation, cellular proliferation, and immunity. We know that obesity has been associated with a reduced risk of premenopausal breast cancer, and obesity can be associated with poor survival among women with breast cancer. This likely is because we see an increase in the levels of estrogen through aromatase activity in the adipose tissue. So studies of hormones secreted by the adipose tissues, including leptin and adipolectin, may also have an underlying association between obesity and breast cancer. Taking a look at environmental chemicals, we see that it's difficult to link it with breast cancer. We have to really consider the life history of chemical exposure. So it's not just one chemical that we're looking at, but a complex mixture of chemicals and their interaction with endogenous hormones. That chemicals in the body can accumulate in adipose tissue and interact with the physiology in our endocrine and paracrine manner and remain in the breast tissue for decades. We also have these xenoestrogens that are synthetic chemicals that can mimic the actions of estrogens, and we find a lot of them in pesticides, fuels, plastics, detergents, and drugs, things that we use in our everyday life or are exposed to in our everyday life, such as car exhaust, our cleaning products, cosmetics, food additives, and hormonal replacement therapy if someone is using that for treatment. So all of that may contribute to the development of breast cancer. Now for physical activity, we know that it's associated with a reduced risk of breast cancer amongst other types of cancers and ailments that we can have in the body. And we find that it may reduce the invasiveness of breast cancer. So if we have a sedentary lifestyle, that may increase our risk. We get increased insulin resistance, inflammation taking place, and a decreased functioning of our immune system. Now let's talk about some of the genetic links here. We have some inherited cancer syndromes, genes, and epigenetic considerations. First, let's discuss genetic heterogeneity. And this is really the genetic profile of a woman in which it's going to be different from person to person and is also going to involve the epigenetic processes. And when I use that term epigenetic, I'm talking about how our behaviors and the environment can cause changes that affect the way that our genes work. Next, we have our phenotypic heterogeneity, and this is going to be when we have that tumor cell plasticity and genetic factors of the tumor that are going to be combined to determine if that cell is going to resist environmental stress and whether that tumor is going to metastasize. We also see that there are increased risk when we have first-degree relatives that have had breast cancer and may have passed down these breast cancer susceptibility genes known as BRCA1 and BRCA2, which stand for breast cancer 1 gene and breast cancer 2 gene. Let's talk about BRCA1 first, and this is going to be located on chromosome 17, and this is a tumor suppressor gene. So any type of mutation in this gene is going to inhibit its suppressor function, and that leads to uncontrollable cellular proliferation. Obviously will increase our risk of breast cancer, but it'll also increase our risk of ovarian cancer. BRCA gene 2 is going to be found on chromosome number 13, and we do find that this is more likely to be found in men that develop breast cancer. Now let's get into the pathophysiology of breast cancer. Most of the adenocarcinomas are going to arise from ductal or lobular epithelium as carcinoma in situ. So we'll get into the names in just a little bit, but I have them listed up over here. And in both of these types, we'll have a proliferation of the epithelial cells that is confined to the ducts and the lobules. We have the infiltrating or invasive ductal type as well. That's when the tumors are going to stay small but metastasize early on, and that is about 70% of breast cancers. Then we've got our heterogeneity, and this term describes the differences between tumors of the same type in different patients, how cancer cells behave as communities, and the cooperative behavior of these groups of cells that can influence cancer progression. So we have to consider that there are genetic, epigenetic, and microenvironmental influences here. And there have been many models of breast carcinogenesis that have been suggested, and they're going to include gene addiction, where we have these driver genes such as HER2 and MYC that are going to play a role in the progression of cancer. We also have phenotype plasticity, which is going to be when we have this distinctive phenotype of epithelial to mesenchymal transition that takes place, where the tissues are going to develop and the organs are going to develop in the embryonic period. And we have a suspension of cell death or apoptosis taking place, and they can be reactivated during processes such as wound healing, or they become resistant to chemotherapy and radiation. So essentially, these tissues are able to change to allow the progression of cancer to take place. We also have reactive or inflammatory stroma, in which tissue reactions are going to increase the risk of tumor invasion and transitions of carcinoma in situ to invasive carcinoma. The other thought is of our cancer stem cells. There's still some ongoing research given this theory, and it's thought that these stem cells are known to correct tissue architecture and may develop the mammary tissue and maintain functionality. So having some type of disruption to our normal stem cells to turn into more cancer stem cells. And then we've got our hormonal outcomes that affect cell turnover of the mammary epithelium, the stem cells, the extracellular matrix, and the immune function. So we see the hormones here as acting as accelerators and initiators in influencing the breast epithelium to become susceptible and develop cancer. Then we have the idea of minimal residual disease, and this is where we had the thought of dormant cells that are not being targeted during chemotherapy or radiation, because those processes are looking at cells that are dividing rapidly, and so these dormant cells stay in there and can perpetuate carcinogenesis and cause relapses to take place. The image that we have down here is illustrating vascular mimicry, and this is going to be the situation in which we have a blood supply pathway within our tumors that are formed, and the tumor cells are able to escape from the primary tumor into the vasculature, so they move through the bloodstream over to distant tissues where they can colonize. And they found that there were two proteins, which you see increased levels over here, SERPINE2 and SLPI, that are promoting that metastasis by stimulating the vascular mimicry, meaning that they are going to resemble and act like our real blood cell tissues. So the tumor cells that express these proteins, which are illustrated in the green here, these green cells, form a vascular-like network that allows the other tumor cells in the purple and blue to move over to that distant site. So I mentioned we talk about the different carcinoma in situs. First, we'll start with ductal carcinoma in situ, which is DCIS. And this type is going to be limited to the breast ducts and the lobules without invasion of the basement membrane. And it can look like invasive cancer if you're looking at this image over here. And originally it was thought that these were precursors to cancer, and they thought you had to remove this carcinoma to reduce the incidence of cancer and mortality, but then studies demonstrated that removal wasn't necessarily going to reduce the incidence of carcinoma. So researchers are now rethinking the strategy for detecting and treating DCIS. Women who are diagnosed with this show that the risk from dying from breast cancer is actually very low. So let's look at lobular carcinoma in situ now. This is going to originate from the terminal duct lobular unit, and we see that it has more of a uniform appearance throughout, and the cells are going to expand, but they don't necessarily distort involved spaces. and the cells start to grow in a non-cohesive manner due to the loss of a tumor suppressive adhesion protein known as E-cadherin. It's typically found as an incidental lesion from biopsy and isn't associated with calcifications or stromal reactions that produce mammographic densities. And the risk factor for invasive carcinoma is high here. It's going to develop in about 25 to 35% of women over the period of 20 to 30 years. Now let's get into the clinical manifestations of breast cancer. We'll see that most of the carcinomas are going to be found in the upper outer quadrant. This is typically how they discuss breast cancer, is through these 4 different quadrants. And we also have this tail that is going to move into the axillary region. And in the upper outer quadrant, we see carcinomas develop more because it's where we have that glandular tissue, and it can easily spread to our lymphatic system because we have so many lymph nodes within this area. And the less common form is going to be in the inner quadrant, which can also spread into our lymphatic system through the mediastinal nodes that are located between our pectoralis major and pectoralis minor muscles. Now, the first sign is typically going to be a painless lump. We can also have palpable nodes in the axilla, dimpling of the skin, or a retraction of the nipple, which you see pictured here, edema, and we can also experience bone pain, especially in the back because of metastasis that may take place extending over into the vertebrae. There are many ways where we can diagnose breast cancer. There's a clinical breast exam, mammography, ultrasound, thermography, MRIs, biopsies, hormone receptor assays, and gene expression profiling. And if breast cancer is found, we have to base the treatment plan on the extent or the stage of the cancer and if it has metastasized. So we may use surgery, radiation, chemotherapy, hormone therapy, or biologic therapy as a part of the treatment plan.